Dr. Kawaguchi is going to speak on the topic of epilepsy and the impacts on women. Dr. Kawaguchi was born and raised in Bellevue, but moved to the East Coast to attend college at the University of Pennsylvania and medical school at New York University School of Medicine. She moved back to Seattle for her medicine internship and neurology residency, which she completed here at UW. She then completed a fellowship in clinical neurophysiology with emphasis in EEG epilepsy at the University of Washington. She recently joined the Neuroscience Institute at UW Medicine Valley Medical Center, where she sees epilepsy and general neurology patients in clinic and admits patients to the hospital for video and EEG monitoring. Please welcome Dr. Kawaguchi.
Thank you, Krista. So, thank you guys for having me today. Actually, a funny story is that I was invited to give this talk on epilepsy and impacts on women, and probably a week later I found out I was pregnant, so I guess it's a pretty fitting topic for me to talk about today. So there are a lot of different topics within this topic of epilepsy and impacts on women. I don't have time to talk about all of them, so I chose kind of the six topics to talk about today that I thought would be the most pertinent and the most important. So first I'll talk about catamenial seizures, which basically are seizures related to the menstrual cycle. And then I'll talk about contraception, pregnancy, breastfeeding, menopause, and lastly, bone health. So starting with catamenial seizures, as I mentioned, catamenial seizures are seizures related to the menstrual cycle. Many women with epilepsy believe that they have catamenial seizures, but actually it only affects about 15% of women with epilepsy. Here's just a schematic of what happens during the menstrual cycle. So it's very complicated. There are a lot of hormones involved. And one of the reasons we believe that women with epilepsy have catamenial seizures is because of the shifts in hormones. So we know from studies that estrogen or estradiol increases the risk of seizures, whereas another hormone called progesterone, here in green, is shown to decrease the risk of seizures. And so you see that there's lots of fluctuations in both estradiol and progesterone. So you can imagine that there could be an increased risk of seizures during some parts of the menstrual cycle. So there are three types of catamenial seizures. The most common type is perimenstrual catamenial seizures. And these happen kind of around the time of menstruation. So it's around the beginning here. Type C2 catamenial seizures are otherwise known as periovulatory catamenial seizures, and those happen on around the time of ovulation. So here's ovulation, so it kind of happens a little before and during ovulation. The third type of catamenial seizure only happens in women who have abnormal menstrual cycles, so they have an ovulatory cycle, so they don't ovulate and their hormones are a little bit off. And they have what's called inadequate luteal phase seizures. So instead of a normal luteal phase where there's lots of progesterone, there are not as many hormones, and they have increased seizures during that period. So as you can see in the perimenstrual phase, there's more estradiol compared to progesterone, and so that increases your seizure risk. And then in the periovulatory phase, there's also a lot more estrogen compared to progesterone, and we think that's why people with periovulatory catamenial seizures have increased seizures during that time. And also, premenstrually, our liver tends to ramp up its metabolism of things like anti-epileptic drugs. So you tend to have lower amounts of anti-epileptic drugs in your bloodstream, and we also think that that leads to catamenial seizures as well. So what can we do about them? There are only a couple randomized control trials that have been done in the treatment of catamenial seizures. So One of them, they looked at taking progesterone. They're kind of lozenges that you take 3 times a day for 2 weeks prior to your menstrual period. And that's been shown to decrease the amount of catamenial seizures, but only in patients who have about three or more times the amount of seizures during their menstrual cycle versus on other days. So it didn't really, it wasn't shown to help people who only had a little bit, extra seizures during their menstrual cycle. Another randomized controlled trial was done in clobazam. And it was a very small trial. There were only 18 patients, but 14 of those 18 patients were shown to have decreased seizures and they took clobazam 20 to 30 milligrams daily. And they started it 2 days before the phase of their increased seizures, and they continued it for 10 days. There are other methods that we use to treat catamenial seizures. They're not supported by randomized controlled trials, but they are used commonly in practice. So probably the most common thing we do is to try to increase the daily dose of the AED during the days of seizure worsening. Some people have tried acetazolamide, which is not even an anti-epileptic drug. It actually is somewhat of a diuretic. We don't know why it works, but it can be helpful in some patients. And you can take that daily for 1 week prior to menses. Another method is you could put yourself on oral contraceptive pills, and instead of doing the week-long placebo phase, you can just take continuous oral contraceptive pills, and that prevents ovulation and all the fluctuation in hormones and can improve catamenial seizures. And then lastly, some patients will try medroxyprogesterone, which is an injectable. You can take it every 10 to 12 weeks. And this has been shown at 1 year to decrease seizure frequency by about 39%. However, it does increase your risk of osteoporosis. And if you do want to become pregnant, there's a slow return to fertility after stopping this. So the next topic is contraception. So an important thing to know about contraception is that certain enzyme-inducing anti-epileptic drugs, and those include, they're here on the side here, so things like carbamazepine, phenytoin, phenobarbital, oxcarbazepine. Here's the new one Dr. Vossler was talking about eslicarbazepine, etc. Topiramate and perampanel, also at high doses, have been shown to be enzyme inducers. And basically, these medications can increase the metabolism of hormones such as progesterone and estrogen, and thereby decrease the efficacy of contraception, so including oral contraceptive pills, the contraceptive patch, Norplant, and the vaginal ring. Oral contraceptive pills have been shown to have a four-fold failure rate in women who are on enzyme-inducing anti-epileptic drugs. So the failure rate goes from 0.7 to 3.1 per 100 women per year. So pretty significant. And the rate might be even higher with low-dose oral contraceptives. So the contraceptives with like low-dose estrogen, for example. Depo-Provera, which is the injectable that people usually take every 12 weeks, hasn't been formally studied, so we don't really know the effects of AEDs on that. So what can we do? So if you are taking an enzyme-inducing AED, there are a couple options. One, you could just switch to a non-enzyme-inducing AED, and that would get rid of that problem. Two, you can always add a second form of contraception, so barrier methods like condoms or diaphragm. Three, so this hasn't been studied again, but some people will do the Depo-Provera, and instead of doing it every 12 weeks, they do it every 10 weeks. And then probably the safest method is to get an IUD, so Mirena or Progestasert, and these are progesterone-coated IUDs. Just a quick note about folic acid. So folic acid is a B vitamin that is usually taken by women who are wanting to get pregnant or who are pregnant, and it's used to decrease the risk of neural tube defects. But the American Academy of Neurology does recommend that all women with epilepsy of childbearing age, no matter if you're trying to get pregnant or not, should take a minimum of 400 micrograms of folic acid supplementation daily, just because there is an increased risk of accidental pregnancies, as well as I'll talk about later, an increased risk of neural tube defects. In particular, women who are taking these medications, so carbamazepine, phenobarbital, phenytoin, primidone, or valproic acid, should probably take a higher dose of folic acid. So the recommended dose is 4 milligrams because there's a higher risk of folate deficiency and neural tube defects. I also just wanted to mention quickly about lamotrigine, in particular in oral contraceptives. So oral contraceptives have been shown to decrease blood levels of lamotrigine. So if you're on lamotrigine and you want to start an oral contraceptive, you definitely should tell your neurologist because you'll need to get your lamotrigine level checked before and after you start the oral contraceptive. And if your levels drop or you have breakthrough seizures, you'll have to increase your lamotrigine dose. And in some cases, it has to be increased by anywhere from 30 to 50%, so a pretty significant amount. And another note is that if you're on oral contraceptives and you're doing the placebo phase, the lamotrigine level could rise during that week, so you could feel a little bit more toxic on your medication during that time. Okay, so next topic is pregnancy. Switching gears. So epilepsy affects about 1 out of 200 women of childbearing age, and 1 in 200 pregnancies actually occur in women with epilepsy, so it's definitely not uncommon. A good thing to note is that over 90% of babies born to women with epilepsy will be completely healthy, and the chances of that are likely higher with early planning and early care by your neurologist and your obstetrician. So don't be discouraged. There are increased complications in pregnancy in women with epilepsy. So we've seen that there are higher rates of gestational hypertension or high blood pressure, higher rates of preeclampsia, which is a condition that happens in your third trimester. It's associated with high blood pressures, protein spills in your urine. It can lead to things like liver dysfunction, kidney dysfunction, fluid can build up in your lungs, so it's definitely not a benign condition. Eclampsia is basically preeclampsia plus seizures, generalized seizures. There's also higher rates of vaginal bleeding in late pregnancy, as well as premature labor. Also, women with epilepsy have slightly increased neonatal and infant mortality rates, higher rates of fetal maldevelopment, which I'll talk about later, higher rates of prematurity and intrauterine growth retardation, so small babies, basically. So many patients ask me about what are my seizures going to be like while I'm pregnant. So the majority of women with epilepsy actually will have no change in seizure frequency during pregnancy. So that's 54 to 80%. And your chances of seizure freedom is higher if you were seizure-free prior to pregnancy. So in the 9 months prior to pregnancy, if you don't have any seizures, you have an 84 to 92% chance of remaining seizure-free during pregnancy. So it's very important if you want to get pregnant to try as best you can to reach seizure freedom before you get pregnant. Unfortunately, seizure frequency may increase in some patients, so about 15 to 32% of women with epilepsy. And we've seen that the risk of seizures is higher in the second and third trimesters of pregnancy, and actually highest postpartum. So some of the causes of increased seizures during pregnancy One is poor pre-pregnancy seizure control, as I mentioned, but also poor medication compliance, which increases seizures anytime, but especially during pregnancy, it's important to be good with taking your medications. Sleep, so we've talked about sleep before in earlier lectures, but sleep deprivation is a very big trigger for seizures when you're pregnant. Also increased stress. And then there are also changes in the metabolism of your medications during pregnancy, especially, again, lamotrigine. So lamotrigine is an anti-epileptic drug that's metabolized primarily via a process called glucuronidation, which you don't have to know anything about, and I actually don't really know how that works either. But basically, all you need to know is that it mainly occurs in the liver, but it does also occur in many other organs, including the placenta. And as we all know, when you're pregnant, you grow a placenta, and it, especially in the second and third trimesters, the placenta is very active. So here's a graph down here. Basically, what it shows down here is the month of pregnancy, so 1 through 10, and then postpartum. And then over here it shows the clearance of lamotrigine. So basically, meaning that the more that the lamotrigine is cleared from your body, the less of it is actually in your body. So you see that as the months go on, more and more lamotrigine is cleared out from your body. And then here in pink, it shows that these patients have increased seizures correlating to the decreased amount of lamotrigine in your body. So if you're on lamotrigine and you get pregnant, you should get your lamotrigine levels checked, ideally before you get pregnant, but if not, during every trimester of pregnancy, as well as postpartum. And depending on the dose, or depending on the level of lamotrigine in your blood, you should get your lamotrigine level adjusted accordingly. So the rule of thumb is if it changes by 25% or more, you probably should get your lamotrigine level adjusted. Or if you have any breakthrough seizures, then obviously your lamotrigine dose should be adjusted. And then postpartum, you should probably go back to your original dose of lamotrigine within about 3 weeks. Some people will have a very kind of precipitous rise in lamotrigine levels and may feel a little bit toxic. So in those cases, you might want to decrease your lamotrigine dose a little quicker after you give birth. So what are the risks of seizures on the pregnancy itself? So as we all know, if you have a generalized convulsion or a secondarily generalized convulsion, you lose consciousness, and that can lead to trauma. And trauma from the seizures may cause what we call placental abruption. So down here in the corner, you see a normal placenta, and it's attached to the uterine wall. In placental abruption, basically, there's a tear, so the placenta tears from the uterine wall. And this can lead to excessive bleeding. It can lead to infections to both the mother and the fetus, premature labor, and in worst case, it can even lead to fetal death. So we definitely want to prevent seizures during pregnancy. Generalized convulsions can also cause metabolic abnormalities. So this can lead to fetal heart rate depression. So basically low heart rates in your baby, fetal hypoxia or lack of oxygen, and acidosis. And if you have status epilepticus, which is basically a prolonged seizure or many seizures clustered together, that's associated with a high maternal and fetal mortality rate. So something we definitely want to prevent. So next I'm going to move on to birth defects. So a lot of women are afraid of taking their anti-epileptic medications during pregnancy because they're worried about birth defects. So we kind of categorize birth defects into minor birth defects and major birth defects. So minor birth defects are basically kind of just purely physical. They don't really affect you negatively. So those include things like widened palpebral fissures. That's just a fancy term for your eye opening is a little bit larger than other people. Epicanthal folds. That's also a fancy term for basically the skin of the upper eyelid covers the middle aspect of your eye. And that can be normal in certain races such as Asians. Small upturned nose, abnormal ears, low hairline, distal finger and toe maldevelopment, small fingernails, and small head size. So what we are concerned about more are the major birth defects. So those include things like orofacial clefts. So here's a picture above with a baby with a cleft lip. People can also get cleft palate, which would be in your palate. Other major birth defects include heart defects, urological, and neural tube defects. So spina bifida is one example of a neural tube defect. And basically, during development of the fetus, the backbones or the vertebrae don't fuse completely. And so you have an outpouching of the spinal cord and sometimes its contents out of the back of the baby. So you see that right here. So the risk of major birth defects in the general population is approximately 2 to 3%. In infants of women with epilepsy, the risk is higher. So it's about 4.5% if you're taking one anti-epileptic drug, and higher at about 8.6% if you're on more than one anti-epileptic drug. So polytherapy and also higher doses of anti-epileptic drugs, as I'll mention later, do increase the risk of birth defects. So here's the risk of major birth defects by medication. So it does vary widely. And this data was taken from the North American AED Pregnancy Registry back in 2012. So valproic acid is associated with the highest risk of major birth defects at around 9%. In particular, valproic acid is associated with a high risk of neural tube defects, hypospadias, which is a urologic defect, cardiac defects, oral clefts, and also infants and babies born to women who have been taking valproic acid have been shown to have a lower IQ. So phenobarbital has the second highest risk of major birth defects at around 5%. And in particular, phenobarbital is associated with a higher risk of cardiac defects and oral clefts. Thirdly, topiramate has about a 4% chance of major birth defects, and it's associated with a higher risk of cleft lip. The other anti-epileptics have kind of varying risk of major birth defects, anywhere from about 1.8 to just below 3%. And it looks like lamotrigine is associated with the least risk of major birth defects. And in this study, the unexposed women had about a 1% chance of major birth defects. So even though major birth defects correlate to the type of medication you're taking, it also actually correlates with the dose of medication that you're taking. So in this chart, we see 3 different anti-epileptics. So this is carbamazepine. In the middle, we have valproic acid. And then to the right, we have lamotrigine. And on this axis, you see the percentage of major birth defects. And then these bars, so the black bars basically represent a low dose of the medication. The white bars represent a medium dose of the medication. And the gray bars represent a high dose of the medication. So you can see within each medication, the higher dose that you're on correlates with an increased risk of major birth defects. So, for example, if you are on a low dose of a less safe anti-epileptic drug such as valproic acid, less than 600 milligrams, it could actually be safer than if you were on a high dose of a, quote, unquote, safer anti-epileptic drug like lamotrigine greater than 200 milligrams. So it's really important to talk to your neurologist about what medications you're on and what your risk is and whether or not you want to change medications or adjust them before you get pregnant. Another question that gets asked is, is the risk of birth defects higher if I have more seizures? And the answer is no. So in this graph, you see the risk of major birth defects down here. And then on this axis, you see the percentage of women who've had seizures. So this actually shows an inverse relationship. So it shows that the women with more seizures had less birth defects. I would take that with a grain of salt. It could be just that these people were on lamotrigine, which has a decreased risk of birth defects. But as I talked about earlier, there's a change in the metabolism of lamotrigine, so maybe they're at increased risk of seizures. So some general guidelines of management during pregnancy. So first and foremost, you want to have seizure control with the minimum effective AED dose. Monotherapy or therapy with one drug is preferable. But if you can't, more than one drug is okay. You want to monitor the blood levels of your AED, especially on certain medications such as lamotrigine, which I talked about, but also carbamazepine and phenytoin. You want to definitely take a daily prenatal vitamin and folic acid. And as I mentioned before, you want to take a higher dose if you're on certain anti-epileptic medications. And then in terms of screening for birth defects, you want to do a prenatal ultrasound at 11 to 13 weeks and a blood test called an AFP, and that can rule out neural tube defects. And you can do a prenatal ultrasound at 18 to 22 weeks, and that you can look at the anatomy of the baby to determine if they have appropriate cardiac development, look at their head and spine anatomy, and look for orofacial clefts, just so you're prepared when you do deliver your baby. Just a quick note on vitamin K. So vitamin K is required to synthesize certain proteins that are needed for blood coagulation or blood clotting, basically. And it's known that enzyme-inducing AEDs can cause decreased vitamin K levels in both the mother and the baby. So this theoretically may increase the risk of hemorrhage or bleeding. So some people recommend that you take vitamin K supplements daily during your last month of pregnancy if you are taking an enzyme-inducing AED. And then on delivery, you could consider getting a shot or IV vitamin K if you're on an enzyme-inducing AED. But this is somewhat controversial, and not everybody practices this. So once you have the baby and you are a mother with epilepsy, some things to note. One, you should try as much as possible to change, feed, and play with your baby on the floor. So if you do end up having a seizure, you're not hurting yourself and the baby. If you are one of the patients who has an aura or a prodrome, it may allow you enough time to get help or set the baby down, but please don't count on this because you never know if you have a seizure kind of out of the blue. Again, sleep, I can't emphasize this enough. You want to get plenty of sleep. When the baby's sleeping, you should try to sleep as well. I know it's easier said than done. And get others to help you with your baby. Okay, so moving on to breastfeeding. So all anti-epileptic drugs are secreted into the breast milk to some extent. An important thing to note is that the levels that they are that they are receiving in the milk is lower than what they were exposed to in utero. Also, the concentration of AEDs in the milk compared to the concentration in the blood is very variable among the different medications. For example, medications like phenytoin are tightly protein bound and aren't secreted into the blood, into the milk as readily. So consider breastfeeding when your AED levels are the lowest. So that would be kind of immediately prior to your next dose. But obviously, if you're breastfeeding every 3 hours, that's not feasible. But if at least one breastfeeding you could do prior to an AED dose, that could be helpful. In general, breastfeeding is very safe. And here's kind of a list based on medications. So in this left column, these are all anti-epileptic drugs that have been around for a long time and that have been studied very extensively, and they've been shown to be safe in breastfeeding. The middle column, I have to say, is moderately safe only because they're newer, and so they have a less well-documented safety profile, but I would consider them safe as well. And only these 4 here on the right are considered contraindicated during breastfeeding, and those include ethosuximide, zonisamide, clonazepam, and diazepam. And one thing to note is that many anti-epileptic drugs may cause sedation in infants. I mean, they cause sedation in you, so they'll definitely cause sedation to your baby. And the ones that are starred are particularly, they cause sedation in particular. So people ask about kind of cognitive effects of breastfeeding while taking an anti-epileptic drug. So there's a study in 2000, or they did a study in 2014. It was the neurodevelopmental effects of anti-epileptic drugs study. And they looked at children who were breastfed by mothers who were taking either carbamazepine, lamotrigine, phenytoin, or valproic acid. So not all the drugs, but very common ones. And they found no adverse cognitive effects of AED exposure via breast milk at age 6 years, so that's very positive. And in fact, these breastfed children exhibited a higher IQ and enhanced verbal abilities compared to non-breastfed children. So breastfeeding has been shown to be beneficial, and so you shouldn't have to worry about breastfeeding if you're on an anti-epileptic drug, unless it's one of the 4 that are contraindicated. Okay, so moving on to menopause. So women with epilepsy do unfortunately have a higher risk of premature menopause. So it's about 14% in women with epilepsy versus 3.7% of controls. Seizure frequency, it really can vary. So it can increase, it can decrease, or it cannot change. The one thing we do know is that the women who had prior catamenial seizures do show correlation with menopause. So they have an increased risk of perimenopausal seizures, or while you're going through menopause, but a decreased risk of postmenopausal seizures. And that sort of makes sense because they were triggered by hormones before, so they're probably very sensitive to hormones during menopause. So just quickly in this graph, during perimenopause, the percentage of women with catamenial seizures had an increased risk of seizures, or increased frequency of seizures, and then postmenopause, you see a decrease in general. Hormone replacement therapy should be avoided as it can increase the risk of seizures. Basically, you're taking a bunch of estrogen, and we learned that estrogen increases your risk of seizures, so you want to avoid this. You can try the lower dose birth control pills or other forms of hormonal contraception. Another thing to note is that when you're going through menopause and once you've completed menopause, your blood levels of the anti-epileptic drugs can change, so your levels should be monitored and adjusted. And a third thing is that, again, sleep. So when you're going through menopause and after menopause, your sleep can definitely be disrupted. and that can lead to increased seizures. So you may want to try sleep medications and or low-dose antidepressants. So lastly, moving on to bone health. So vitamin D and calcium are very important to our bone health. We get our vitamin D from sunlight, well, not so much here, but in other parts of the world, and also our diet. And vitamin D also increases the absorption of calcium, and a lot of that is important to our bones. So AED exposure can increase bone loss. It can affect bone and mineral metabolism, and that can cause secondary osteoporosis. The risk is higher with enzyme-inducing AEDs. Back to that again. Phenytoin in particular has been shown to reduce vitamin D absorption. So in anyone with epilepsy, actually, you should get your vitamin D levels checked periodically. And also, you should get your bone density checked. This is mostly for postmenopausal women, but also in women who have taken anti-epileptic drugs for a long time. Actually, both women and men. So general recommendations is that you should take a calcium and vitamin D supplement every day, and you should take a higher supplement of vitamin D if you have osteoporosis, plus maybe a bisphosphonate or other medication to help with osteoporosis. Some lifestyle measures that may decrease the risk of osteoporotic fractures. So you should do weight-bearing exercises regularly. If you're smoking, definitely quit smoking, not just for this, but for your health in general. You should limit alcohol intake, and you should be careful to prevent falls. So use a cane or a walker or whatever you need to prevent falls. And then you may want to avoid other medications that can also decrease bone density. Okay, so take-home points from this lecture today. 1, so catamenial seizures can be treated with hormones and or other medications. So talk to your doctor if you think you have catamenial seizures. Enzyme-inducing AEDs can make contraception less effective. That very important point. IUDs are the safest bet in this case. Both contraceptives and pregnancy can decrease the levels of lamotrigine. All women with epilepsy of childbearing age should take a folic acid supplement every day. Pregnancy is associated with increased risks to both the mother and the infant. Anti-epileptic drugs have varying risks of major birth defects, and it seems also have to do with the dose of the medicine. Breastfeeding is generally safe and recommended. Menopause may change the frequency of seizures, and definitely avoid hormone replacement therapy. And finally, bone health is important, so take calcium and vitamin D supplement. And then most importantly, talk to your doctor. So every situation is unique. You should discuss any and all concerns and questions with your neurologist and or obstetrician. And early planning is key. Here's some references. Any questions? Oh.
Anti-epileptic medicine your whole life, would that be a cause of bone loss?
It could be. I mean, there are certain anti-epileptic drugs that predispose you more to osteoporosis than others, but there are also other causes of osteoporosis. So I guess it would depend. But
Is there any way of getting the bone, any way of strengthening the bone or getting it back?
So you could take medicines like the bisphosphonates. They can help with osteoporosis. And then kind of the things I mentioned, so weight-bearing exercises, avoiding smoking, things like that could be helpful.
I was wondering if there's any correlation with taking anti-epileptic drugs during like the preteen years and menstrual development.
What do you mean
delay. Like,
delay. So, I mean, I didn't get a chance to talk about puberty today. There are changes in seizure frequency. There are also changes in puberty in women with epilepsy in general. I'm not sure if it necessarily has anything to do with the medications.
Related to that, prepubescent girls, are there any signs or indications of whether or not their seizures will become worse or change with puberty?
I mean, I guess it depends on the person. So some women are just more predisposed to being affected by hormones than others. So I think you kind of have to watch and wait and see what happens.
So what are your thoughts on, so my daughter's 18, just started having seizures 4 months ago, has never really gotten her period except induced with a medication. We thought about putting her on the birth control pill, but now we don't want to do that because she's on lamotrigine. Any correlation with like never really getting your period? And because when you talked about that, the third one where you don't have your period.
Yeah, so actually, and I didn't get a chance also to talk about fertility and puberty. So women with epilepsy do have decreased fertility. Also, women with epilepsy have a higher risk of PCOS or polycystic ovarian syndrome, and also other kind of menstrual irregularities. So it could be related to her epilepsy. Thank you so much.